Nice to see you again.
Good to see you. So, ladies and gentlemen, good evening. Hello, everyone. Welcome to our second podcast. And today I'm truly honored to be joined by someone who needs very little introduction in pediatric endocrinology, Professor Nandu Thalange. He is very well known, internationally respected pediatric endocrinologist, educator, and leader who has shaped how many of us think about different pediatric endocrine disorders. What I personally admire about Professor Thalange is not just his academic contribution, but his clarity of thought, clinical wisdom, and most importantly, his humbleness. So, Professor Thalange, thank you very much for joining us today.
Thank you very much for the invitation. I'm delighted to be back again talking to you. So thank you very much indeed. And I hope that the podcast is well received by the audience out there.
Yeah, well, it is very well received and very much liked because you are enlightening us with a pearl of wisdom. Right. So, talking about diabetes insipidus, what is the new terms and medical terms of instead of DI?
So diabetes insipidus has obviously been a term that's really been around for a long time since it was recognized to be a distinct entity. And it actually comes from the same origins as diabetes mellitus, mellitus meaning like honey, sweet. So when doctors used to taste the urine, it tasted sweet if you had diabetes mellitus. And in diabetes insipidus, you would have the polyuria and polydipsia, but the urine didn't really taste of much. It was insipid. And that's where this name comes from. But unfortunately, that juxtaposition of the diabetes insipidus and diabetes mellitus has led to confusion over the years. And in a questionnaire that preceded the recommended change of nomenclature in 2022, 85% of patients with what used to be called diabetes insipidus reported that healthcare professionals had mistakenly thought they had diabetes mellitus and not diabetes insipidus. So I think, and there have been tragically deaths. I mean, I remember one very sad case in the UK of a young man, a student of 19, I think, who died in Ealing Hospital after his diabetes insipidus was not treated adequately with fluids, and he was thought to have the wrong kind of diabetes, essentially. So it's not only a foolishness, it can actually have fatal consequences to misunderstand what you're dealing with. The new nomenclature really is much more straightforward in a sense. I mean, the only difficulty, I guess, will be going forward that you'll have to look up different terms. You want to look back historically at something that was done in 2010 or whatever, then you'll have to look for diabetes insipidus. But at least in the future, I think we should be using the terms arginine vasopressin, that's the proper name for ADH, antidiuretic hormone, so arginine vasopressin or AVP, and that can be AVP deficiency, you're not making enough of it, or AVP resistance, you're making it, but it doesn't work. And there could be a variety of reasons for either of those situations.
Why do you think disorders of arginine vasopressin remain one of the most commonly misunderstood areas in pediatric endocrinology?
Yes, I mean, I think it's relatively uncommon to see, so it's a rare disorder anyway. Um, and a lot of the cases are seen in post-operatively, people undergoing neurosurgery or have had severe head injuries or have had brain tumors. And I think, therefore, a lot of the expertise in this area is sort of rather hived off to select establishments rather than being the generality that many people will see a lot of in their endocrine training. And I think there are some shortcomings in the appreciation, the clinical appreciation of diabetes insipidus. Sorry, I'm reverting of AVP
AVP.
deficiency. Apologies. So I think there are some shortcomings in that understanding. Um, and also, I think there are some real, what I would call bear traps that people sometimes step into when they're managing AVP deficiency. So I think there's a lot to talk about in this important topic, actually.
Yeah. Do you think we oversimplify the AVP, whether it's deficiency or resistance, in teaching, clinical teachings?
Uh, I mean, it is dichotomous, but of course, all hormone deficiencies are relative. You know, you can have a very severe deficiency or a partial deficiency, which is probably more common. I mean, you need to lose over 80% of your AVP uh, secretion before you get AVP deficiency. So your body can compensate really rather well because if you don't make enough AVP, you drink more. You're thirsty, so you have a relative thirst, maybe not the tremendous thirst of the patient who's got an acute loss of AVP from a craniopharyngioma, for example, and they have profound polyuria, polydipsia, and that's a very dramatic presentation. And I would hope that all of our endocrine colleagues would pick that up pretty quickly. But I think the more subtle cases, it can be a slow evolution. You can imagine if you've got Langerhans cell histiocytosis affecting the pituitary stalk or some slowly progressive tumor like a germinoma in the hypothalamus, that this can be really quite an insidious onset. So the thirst creeps up, and the patient just adjusts. They drink more and more, and eventually the parent, in our case as pediatric endocrinologists, recognizes, gosh, this child is drinking a tremendous amount of water. And I had one boy recently who presented to me at the age of 9. So 4 years he'd had this thirst, and is actually probably gone on for longer than that. His mother told me that the school teacher had commented when he had started school at 5, why does he drink so much? And that was what had first caused her to recognize that he was drinking a lot. And she just made sure he had enough water to drink, and he would drink. This is a small boy at the time. He's obviously a bit older now, but he was drinking 2.5, 3 liters of water a day, which is unusual, I would say, for children to drink a lot of water. They might drink a lot, but it's not usually water that they're choosing to drink. Whereas if you're really thirsty, you will drink water. You'll drink anything, actually.
Yeah. I had a case
But
actually. The history was the kid is just drinking from the tap constantly. That was a
mm,
bit unusual, different from his siblings, because he just opened the tap and that's just drink until he gets full. Right,
well,
so I think
there are these.
yeah, you're taking us to the physiology. So can you just run a kind of refresher explanations of
Yes.
how the AVP work, what pathway that
Okay.
is involving?
So AVP is secreted actually from largely the supraoptic nucleus and the paraventricular nucleus of the hypothalamus. It's secreted in the neuronal cell bodies. The AVP descends down the axons into the posterior pituitary, where it is stored, ready for secretion into the venous plexus that surrounds the pituitary, and the signal to release the AVP is either osmolality, and osmolality, essentially the concentration of blood, is very tightly regulated between about 275 and 295 milliosmoles per kilogram, and also volume depletion. And there is a third regulator, which I'll come to in a moment. But the second regulator, volume depletion, really only cuts in when you've lost 8 to 10% of your blood volume. But the important thing to realize there is that happens regardless of your osmolality. So if you lose enough volume, let's say you're suffering from a shock after trauma, even though your blood concentration, the osmolality is perfectly normal, you're still volume depleted, so you start secreting ADH. And there is a third consideration, which is that stress also has an impact on AVP secretion. And if you're in a stressful situation, you can secrete AVP regardless of the fact that you have normal osmolality and no volume depletion. And we recognize that classically in, for example, respiratory illnesses presenting with syndrome of inappropriate ADH secretion. And that's an important thing to remember because some of the children with complex neuroanatomical abnormalities, for example, septo-optic dysplasia or some of these, holoprosencephaly, they have this really complex regulation where most of the time, yes, they have florid AVP deficiency, but then they get ill and they start secreting AVP because the stress response to AVP is still present, still intact, and still functioning. And I'm sure you may have seen this. I certainly have seen it a number of times over the years. And the child who's perfectly controlled on the standard dose of desmopressin, and you're not having to change the dose from one visit to the next, and suddenly they come in and they've got a sodium of 121 because you're not expecting not to need AVP or DDAVP in that child. And but then when you give AVP and the child is making actually a ton of it and it's not regulated by osmolality, then you can quickly end up in trouble. And actually, one of the important things that we sort of alluded to it earlier, really, one of the pitfalls in replacing ADH or AVP is don't try to give 100% replacement. And it doesn't matter if the sodium is slightly high. I think often, part of our, as it were, physiological upbringing in medical school is you've got to normalize the physiology. Well, actually, the patient with AVP deficiency is quite happy with a sodium of 152. They don't have a problem with that. The doctor may have a problem with it. It's a sign of their underlying illness, but they just drink to the increased sodium or the increased osmolality. So let their thirst be your savior in that situation. It's much better to do that than to give them too much AVP and then potentially trigger hyponatremic seizures, which I've certainly seen in this condition.
But what about if the thirst is not intact? The thirst
Yes, so that's
sensation.
true. So there are those poor patients who have lost their thirst perception. And to be honest, these are the most challenging and difficult patients to manage because without that safety net of the thirst mechanism, you're really in trouble. You're treading the tightrope there. And you don't have that many easy tools. I mean, I had one boy who had this problem in the UK, and we actually got him a home electrolyte analyzer. So Abbott makes a device called the iStat, and so it was actually more cost effective for the health system for his family to have an iStat so they could check the electrolytes at home rather than him having to come to hospital every time, ending up waiting 3 hours potentially in a dangerous situation, and then being met by general puzzlement and confusion by doctors who didn't know what they were doing. So actually, the parents were much better at looking after him than the doctors were in general. So
That's
yeah,
true.
we actually found that to be an effective strategy. But I mean, it's not easy, and it's obviously, you have to have a very, very committed, able um, parents to take that on. I'm not saying that's the standard, but you know, if you don't have the first mechanism, you're at really high risk of severe hypernatremia. And hypernatremia, essentially hypernatremia is, if you think about what osmolality is made of, it's twice your sodium, twice your potassium, plus glucose in millimoles, plus urea in millimoles. And so therefore, if your sodium is high, that's got a massive impact on your osmolality. So essentially, osmolality and sodium are the same. And if you've got hypernatremia, then you're at high risk of intravascular thromboses, and that's definitely the last thing you need if you already have a problem regulating fluid balance, to infarct your left kidney or something. So it's a tricky situation if you lack thirst, and unfortunately, and maybe you've had this experience as well. I think many of these children do unfortunately come to grief because of either failure to recognize the problem or mismanagement of the problem when they do come to hospital with illness.
That's true. That's true. Right. You mentioned earlier that there is a AVP deficiency or AVP resistance. Clinically, how useful is the classic division into these two subtypes? Does it always help us at the bedside, management-wise?
Yeah, I mean, I think yes, because the treatment is completely different, basically. I mean, in AVP deficiency, we have a treatment. We have synthetic AVP in the form of des-diamino arginine vasopressin, which gives it a bit of a longer life, around I would say 8 to 12 hours in most cases, but occasionally you find someone who is able to manage with just one dose a day. But in general, it's a very effective replacement treatment, simple strategy. Now, if you have AVP resistance, your AVP isn't working. If it's genetic, then it presents obviously in infancy, and those poor babies, they're just chronically thirsty. They have severe failure to thrive, and their electrolytes are dramatically abnormal. And it can be quite tricky to diagnose AVP resistance in a baby because they drink so much anyway. So I think people aren't thinking about, well, what's the amount of liquid you're consuming? And so they're in a chronically dehydrated state because people aren't giving them enough. When a child starts to get a bit bigger, then it starts to be obvious that they're just chronically thirsty and want to have fluid. And so AVP resistance, if it's genetic anyway, is mainly an X-linked disorder. So the AVP receptor, the vasopressin 2 receptor, is an X-linked gene, and it's therefore you could have a carrier mother who herself doesn't have any symptoms, who passes on the condition to her male offspring, and or you may have um, a more clear family history. It obviously depends on, because it's the male relatives that show it. But I think, we in endocrinology and with a good awareness of genetics are on the ball when it comes to picking up X-linked disorders. But I don't know that necessarily that's going to be the experience of most people when they go to see the pediatrician. Um, so the AVP deficiency is relatively straightforward, I would say. You've got the AVP, sorry, you haven't got the AVP, so you replace it. AVP resistance, AVP doesn't work. If you give desmopressin or DDAVP to a child with AVP resistance, it doesn't do anything. It doesn't help in any way. Um, and so I mentioned that, so 90% of DI is, oh, sorry, I'm reverting. 90% of AVP resistance is due to mutations in the V2 receptor, the vasopressin 2 receptor in the nephron, and the other 10% is not sex-linked. That's due to mutations in the aquaporin 2 gene on chromosome 12. And those mutations are usually autosomal recessive, which means they're incredibly rare. But there are some, also incredibly rare autosomal dominant causes of AVP resistance due to mutations in aquaporin 2 affecting gene expression, so that basically the gene, or rather the aquaporin 2 is expressed on the cell surface, on the basolateral membrane, but doesn't work. But AVP, or rather aquaporin 2, has to form a complex with other aquaporin 2 monomers. And so if you got a defective one, it messes up the whole complex and you end up with autosomal dominant AVP resistance. And that's very tricky.
Okay.
I think acquired AVP resistance is relatively uncommon, but by far the commonest reason for it would be renal impairment, so chronic kidney disease. And some disorders can look like it. So if you've got a severe renal tubulopathy, some renal tubular acidosis or cystinosis or something like that, then you will get a polyuria because there is impaired solute retention and fluid loss. It's not actually that you have diabetes insipidus. There I am again, wrong word, AVP resistance, but it's similar, and the treatment is similar in the sense that in AVP resistance we poison the kidneys. That's the treatment. So we normally would use thiazide diuretic, which has this paradoxical effect. You think, what, you give a diuretic to the child with AVP resistance? And actually it reduces renal losses of water, and also we can poison the kidneys with indomethacin. So if you need something more potent to get things under control, which often you may, for example, in a pubertal child with AVP resistance, you just need to control the fluid loss a bit better. Then indomethacin is effective. I have to say they're nasty treatments to use in the long run, and they do incur their own risk of chronic renal impairment. So obviously thiazides tend to be associated with nephrocalcinosis, and indomethacin being a powerful non-steroidal, the non-steroidals are also very toxic to the kidneys and can cause an tubulo-interstitial nephritis. And that itself can be associated with hypokalemia. Hypokalemia is another cause of resistance to AVP, actually. So it's a sort of all compounding. So mostly the AVP resistance that we see in pediatrics is either genetic, and if it's not genetic, it's severe renal disease of some sort. I don't think we see children, taking lithium or, with other severe pictures. We do see that in adult patients, that they could have some other reason for it. But I would say that I have never seen a child with drug-induced AVP
AVP.
resistance. Yeah.
Yeah, I thought you were going to say DI.
Sorry, I contained myself at the last minute.
All right. So how can the clinician differentiate between these two subtypes, and where do you put the partial DI in this equation?
Well, so I personally, I mean, because we've spoken about it in the past, that I am a deep skeptic about many of the stimulation tests used in endocrinology, and possibly the most useless test in endocrinology is the water deprivation test. This is an evil test that is really not tolerated well. And if you have diabetes and if you have AVP resistance, it's a dangerous, sorry, AVP deficiency, it's a dangerous test. So I think, we have much better tools, and the test that I think is by far superior to the water deprivation test is the arginine test. So arginine, which some of you may already be using as a growth hormone stimulation test agent, can also be used to stimulate AVP secretion. And so you give arginine in the standard way, infused over 30 minutes, 0.5 grams per kilogram, maximum 30 grams. And then you look at the rise in AVP, or better still, in copeptin. So I think one of the problems with measuring AVP, historically, we didn't really do it in the UK because it was costly to do. The blood sample had to be flash frozen in liquid nitrogen, then transported to Newcastle, which was the only lab in the country that did it. But then it was discovered that, I suppose a bit like insulin, AVP has its own, not C-peptide, but copeptin, its own co-secreted fragment of the precursor molecule. And copeptin is much more stable in plasma. It's secreted one-to-one with AVP, so it's very stable, relatively easy to measure, in contrast to AVP itself. And you don't have to have this hassle of immediately rushing to the lab with the sample. And also the AVP test, rather the arginine AVP test, is a very simple test. It can be done in as short a time as an hour. So you take your baseline sample at 0 and you take your blood sample at 1 hour, and you literally look at the 1 hour sample and see how the copeptin has changed. If your copeptin is below 4 at 1 hour, you have AVP deficiency. If you have a high copeptin, if it's over 20 picomoles per liter, then you have AVP resistance. And of course, there are always some gray areas. So there are some people that are in the gray zone where the copeptin's between about 3 and 5.5, where there could be a degree of AVP deficiency. But I think if you have AVP resistance, it's a very simple, distinction between the two. So it's a simple test, it's a safe test, and if it's relevant, you could be potentially combining that with a growth hormone test, which you may well be if you've got a child. For example, the last time I did this test was in a child after craniopharyngioma, and I wanted to assess the growth hormone axis as well as their AVP renal axis, because they had the classic triad after surgery where they initially had, so they presented with, or they had polyuria at presentation, and then they had their surgery, then they became sodium water retaining. They had the temporary secretion of AVP, which didn't persist, and then they became AVP deficient again. And then it appeared to get better. So I was testing her arginine test, vastly simpler test, straightforward test, safe test, and a clear distinction between AVP deficiency and AVP resistance. And, anyone who's spent any amount of time doing water deprivation tests knows how difficult they are to do. The children themselves become hugely distressed. The parents become distressed. The parents will covertly give fluid to the distressed child because they can't bear it. And so the test is often a very imperfect test, and I think the arginine test, it's a straightforward test, not unpleasant. It's not like the hypertonic saline test, which also has risks. Um, it's not quite as good as the hypertonic saline test, but then, the arginine test is a test you can easily do again. I don't see
Safer.
people queuing up to have a repeat water deprivation test or
Yeah.
a hypertonic saline test. So
Yeah. But do you think the copeptin marker measurement is it available? Is it widely available in the
I
region?
think it's a pretty standard lab marker. It is available. It's obviously a test that's not done so much, but it's what it's measuring directly what you should be measuring, which is how much AVP are you making, uh, and um, and that ultimately the bottom line. Even if you do a water deprivation test and you think, oh, this child has DI or rather AVP deficiency, you still end up having to measure the AVP anyway. So you might as well just get on with it and measure it directly. Um, I mean, obviously, if you're in a center or a part of the world where copeptin measurement is not available, then that's going to be difficult for you. But I honestly think the if you possibly can, you should be avoiding tests that are potentially hazardous to the child. I always say about growth hormone tests, no one died from being short. Well, the water deprivation test is a test that can kill you if you have AVP deficiency or resistance for that matter. Well, it's less likely with that. So I certainly would do my utmost to avoid doing that. And sometimes you have to call it as you see it. If you really have a high threshold of suspicion that the child in front of you has AVP deficiency, then to be honest, I'm normally ordering an MRI scan on that child because the thing I don't want to do is to spend 6 weeks failing to diagnose their brain tumor. Uh, you know, it, I had a child with exactly this situation, a different child with craniopharyngioma. The mother told me she'd been going from endocrinologist to endocrinologist in UAE for 18 months, and she wanted this water deprivation test that she'd read about because she was convinced her son had this. And I said, well, let's do the MRI. Um, and he unfortunately he sadly had a craniopharyngioma. So I think it's not a diagnosis you want to delay making. So if you really think on clinical grounds, gosh, this is highly likely to be AVP deficiency, do the MRI. And if the MRI is consistent with AVP deficiency, either a destructive lesion affecting the pituitary or absence of the bright spot, then it's a straightforward thing to do an empirical test with AVP treatment itself. You give them the desmopressin, and the child and the parents, thank you with tears in their eyes when they see you a week later for this repeat sodium measurement, because, for the first time in months or even years, they can sleep through the night, they can manage a day at school, all of the normal things we take for granted, they can do again.
What's your interpretation for, you just mentioned the absence of the bright spot, but what's your interpretation of someone who's got absent bright spot on the MRI, but it's not polyuric, not polydipsic, and all the
Ah,
labs are
well, so
normal?
this is an important point actually. So the bright spot or absence of the bright spot does not mean you have AVP deficiency. It means you may do in the right clinical context. And this is one of the things I always emphasize about endocrine testing. You have to have the right clinical context. So, for example, if I was unwell with gastroenteritis 2 days ago, I would deplete all my AVP in my pituitary. And all of that stored AVP in the magnocellular cellular neurons would have been drained. So my MRI would show an absent bright spot, but it wouldn't mean I had AVP deficiency. It would mean that I'd used all my AVP. So I think, if a child has had a recent dehydrating illness, that could easily account for that. It's said, if you read the radiology literature, it said that in 5% of cases with absent pituitary bright spot, there is no underlying clinical deficiency of
Mm.
AVP. So it is recognized, and I think one should be aware of it. But there's physiological reasons for that. The reason we see the bright spot is because of those storage granules in the neurons, which have been potentially can be depleted in time of need. So if that child has just been through a time of need, then you won't see the bright spot, even if they can make AVP.
Okay. If you had to give one practical rule that all or every pediatrician should be remembering when faced with polyuria and polydipsia, what would it be?
Well, I think still, numerically, going back to the very beginning of our discussion, diabetes mellitus is still a much more common diagnosis. So don't miss that, obviously. And it's very easy to put a dipstick in the urine or to do a capillary blood glucose sample or an HbA1c test to exclude diabetes mellitus. And that's absolutely straightforward and essential in any child, really, who's got a new onset polyuria polydipsia. But assuming those things don't apply, you've got no evidence of diabetes mellitus, then you're firmly in the territory of AVP deficiency, more likely, or less commonly, AVP resistance. And in that situation, you have to get your MRI request done, I think. I mean, my first port of call, if I suspect AVP deficiency in an acute onset case, would be MRI. If there's an acute onset, that's a brain tumor until I know otherwise. If it's AVP resistance, then you obviously have to look for secondary poisoning from other agents, such as lithium. I did have one boy with lithium poisoning, but it was actually from a lithium battery he had swallowed. And we had no idea why he was unconscious. And we did a chest X-ray looking for occult infection and saw the battery in his esophagus. And that was actually lithium poisoning that was causing his unconsciousness. So you do
Goodness me.
see some unusual cases, but I've never seen lithium as a cause of AVP resistance in a child.
Okay, so in the last couple of minutes of our podcast tonight, I have a very rapid fire questions. What is the most
Okay.
dangerous mistake in AVP disorders?
Um, Trying to be perfect with AVP replacement. Don't do that. Just let thirst speak for the child. Let the child's thirst be their safety net, and don't overdose them with DDAVP. Uh, and be aware that in certain situations, particularly in those children with complex neuroanatomical abnormalities, you can have resurrection of DDAVP or other AVP secretion by the pituitary, analogous to the syndrome of inappropriate ADH secretion. So be very careful in children with those complex neurodisability pictures that often have an underlying neuroanatomical
What is the
abnormality.
most reassuring sign?
Uh, a normal sodium and a well child, obviously. Uh,
Good.
Child that does not live by sodium alone, but the sodium is a very good clue. It's a very quick shorthand because as I explained earlier, sodium is by far the biggest component of osmolality. So even if you don't have easy access to osmolality, first of all, you can calculate it from the formula we
Okay.
talked about, but also you can just measure the sodium, and that's going to be 90% of your osmolality. So that'll give you an idea what your osmolality is. If the sodium is normal or only slightly high, you don't have to worry. Because in the child with AVP deficiency, they're used to having a slightly high sodium, and often they feel better with a slightly high sodium, in fact.
Okay.
My
Talking about
colleague
infants.
in, sorry,
Yeah, yeah. Go on, tell us about your colleague.
I was going to say my colleague in Dubai who joined me, Dr. Mireille Al-Bejani, wonderful endocrinologist. She was always slightly anxious with my management of these children when I said, "Oh, sodium's 158, it's fine," because actually they're very, very tolerant of hypernatremia. You don't want to have the sodium, in the 160s, but I think up to a point, these children are very tolerant of high sodium, so don't get greatly exercised about the sodium.
Okay. Since we talked about investigations, tell me about one lab value never to interpret alone in this context.
Mm. Well,
Osmolarities, maybe?
yeah, I think that, yes, osmolality. So if you have the plasma osmolality, then ideally you want a paired urine osmolality at the same time. Because, if, I mean, for example, the boy I mentioned recently who had been AVP deficient for years, I did his urine osmolality and it was undetectable. He had such dilute urine, it was water, whereas his plasma osmolality was high. So, that's a picture you don't really see in any other situation, assuming he's not doing strange things with sodium.
And the last question is, what would you say about teaching ABP disorder in one paragraph?
One paragraph. Well, think about if you're suspecting AVP deficiency, think about what the cause is, because the cause may be something very serious and that needs urgent management, such as a brain tumor. The child I mentioned with craniopharyngioma had critical impingement of the tumor on his um, chiasm, and so he was actually already in a state of impending visual loss. And if you have AVP resistance, which is a rather rare condition, then obviously you need to involve your nephrology colleagues. They're going to be very critical in helping you get to the bottom of what's going on.
Lovely. Thank you very much for your time. Thank you very much for this beautifully explained, very important and complex topic. You made it easy for us tonight. We hope to see you again in another subject. Keep
I
well
look
and stay
forward to
safe,
it.
and I'll see you again.
Thank you very much, Hussein, and thank you for all that you do in Pet Endo Club, and thank you to all of you who are watching.
Thank you very much.